So autoimmune hepatitis overview. So autoimmune hepatitis is relatively rare, but very heterogeneous in how it actually presents. And sometimes that makes it challenging to pinpoint the diagnosis and treat accordingly. The recently published online, the 2025 AIH practice guideline by the EASL had clearly defined some of the different ways of presentation with autoimmune hepatitis. As we all know, it can affect anyone at any age in any background, genetic background. So it can affect children, it can affect adults in older adults or younger adults. And some patients could present with just abnormal liver enzymes, not having symptoms, to some of our patients presenting with acute liver failure, really needing liver transplant. We also could see patients presenting with acute and chronic liver failure in a background of previously undiagnosed cirrhosis. So it is really important that we keep autoimmune hepatitis in the differential diagnosis of anyone presenting with abnormal liver enzymes. So the working pathogenesis for AIH, John and Michael probably will speak better on this, is that often, not always, there could be an environmental trigger, sometimes maybe not, leading to a failure of immune tolerance in an individual with inability to differentiate self from non-self. And that individual could be genetically predisposed. In collaboration, all these factors will actually lead to T-cell mediated attack on the liver antigens, leading to progressive necrosis, inflammation, and fibrosis over time. Its prevalence is around 15 to 25 per 100,000 population, a bit more common in women than men, with a ratio of 3.6 to 1, so mostly does affect women. And as I stated earlier, it can affect any ethnic group at any ages. So we really have to think about AIH as a differential diagnosis and anyone at any continent that you're managing with elevated liver enzymes. So there are some classic or typical pattern of someone's presentation, clinical presentation, that will make you think that it could be autoimmune hepatitis. Mostly is hepatitic in pattern, meaning we usually see elevated AST and ALT a bit more pronounced than jaundice, unless they're presenting with, again, liver failure, either acute liver failure or acute and chronic liver failure in someone with an underlying cirrhosis. So hepatitic pattern, elevation liver enzymes. Often we will see elevated gamma globulin. So I think I will correct this. The newer guideline does factor IgG, but the level of the IgG elevation is, I think, the question. So we still see elevated gamma globulin in autoimmune hepatitis. There are classic autoantibodies that we can measure that are positive, knowing that around 20 to 25% of the cases could have seronegative AIH. So the positive antibodies that we could see include anti-actin or anti-smooth muscle antibody, anti-liver kidney microsomal antibody, anti-liver cytosol 1 antibody, and anti-soluble liver antigen, liver pancreas antibody. These are some of the classic ones, and I will specify them based on the different categories of AIH. On liver biopsy, we do see interface hepatitis, mostly plasmacytic inflammation on histology. And classically, autoimmune hepatitis actually does respond to immunosuppression. Sometimes that is used in making the diagnosis. It is important that we get a thorough history, since about 20+% of patients with AIH could have other autoimmune conditions, such as type 1 diabetes, Graves' disease, Hashimoto's. So we need to do a thorough personal history as well as first-degree family history, as about 40% of patients have relatives with some form of autoimmune conditions. This table is from the recently published, online published EASL AIH guideline. I think it was published in just recently in June of 2025, which factors in the initial, the International Autoimmune Hepatitis Study Group did come up with a autoimmune hepatitis definition to make the diagnosis. Initially, I think it was in 1999. It was updated in 2008, and this recent one was from 2025, where there are different variables, and we gave different points to them and trying to make the diagnosis of AIH firm. So some of the factors that are measured are ANA. Some of the antibodies are ANA or anti-smooth muscle antibody, IgG, liver biopsy findings. These are compatible or typical to AIH, and making sure that viral hepatitis has been ruled out. So the newer criteria gets rid of the titer for example, for anti-smooth muscle antibody, and you get 0, 1, or 2 points. And the IgG level either normal or greater than the upper limit of normal, liver biopsy normal or compatible or typical to AIH. And based on adding the score, if your score is above or equal to 6, is probably AIH, and if it's above or equal to 7, it's definite AIH. So there are different subtypes of autoimmune hepatitis, classically 2. Type 1 autoimmune hepatitis is about 90% of the cases with AIH. Excuse me 1 second. And type 1 autoimmune hepatitis often have ANA positivity, anti-actin antibody positivity, and or anti-SLA or liver pancreas antibody positivity. Usually the onset is at any age. They can present with variable clinical or histopathologic severity. About 80% of the patients are steroid responsive. And they do have variable relapse rate after drug is withdrawal. So type 1 autoimmune hepatitis, about 90% of the AIH cases are type 1. Classically, again, they have ANA or anti-actin antibody positivity, and they can present at any age. Type 2 autoimmune hepatitis, on the other hand, is about 10% of the autoimmune hepatitis cases. Classically, they have anti-LKM antibody positivity or LC1 antibody positivity. Presentation is usually in childhood or young adults. Compared to type 1 autoimmune hepatitis, they do frequently present with acute liver failure and less frequently with cirrhosis. The key thing, I have few patients, is again not that common. The key thing for the type 2 autoimmune hepatitis cases is that they frequently relapse if you're trying to withdraw immunosuppression. And so it is important, most of them should really be treated with maintenance long-term immunosuppression. I think withdrawal or titrating down immunosuppression can be challenging as they tend to relapse. So once we make the diagnosis of autoimmune hepatitis, who should be treated? Strongly, treatment is recommended for those that are presenting with advanced fibrosis or cirrhosis, because you're trying to control any inflammation from leading to liver failure. Unless they have burnt out cirrhosis with significant liver failure, I think we should think about treating those that have advanced fibrosis or cirrhosis, and those that have significant necroinflammation should be treated. Treatment can be optional in mild cases where just the liver enzymes are just mildly elevated and you're not seeing significant inflammation on the liver biopsy, particularly if patients have comorbidities, advanced age, could be one of them. And some patients may not want to be on immunosuppression, but you could, if it is a mild disease where you're entertaining about treatment or not, you should, however, monitor them closely, as there could be a flare needing a treatment. So they should be watched closely. So what is the mission, the initial mission of what's our goal in treating autoimmune hepatitis? Our goal is initially to induce a remission. So what do we use? Classically, we start with prednisone, 0.5 to 1 milligram per kilogram per day, maxed about 60 milligram per day. Sometimes if we have severe fulminant autoimmune hepatitis, we could go up to 100 milligrams per day. But if they are not responding within 7 days, this is a group that actually should be considered for liver transplantation, as their response rate is really low, about 20%. So traditionally, up to 60 milligram, 0.5 to 1 mg per kg, slightly higher dose in those with fulminant autoimmune hepatitis. And milder diseases, you can start at a lower dose and titrate up as needed. So it can be personalized. In addition to prednisone, we traditionally add azathioprine. Classically, if there is jaundice, we should wait till the bilirubin is less than 6 milligram per deciliter. And we can increase the dose based on a response and tolerance, with typical dose up to 1 to 2 milligram per kilogram per day. If we're using 6-AMP, a lower dose needs to be used, as there is 2-to-1 conversion factor. There is emerging data indicating that mycophenolate may be a little bit more superior than azathioprine. This study that I cited is an open label randomized control, but open label study where patients tolerated mycophenolate very well and they had a higher response rate. So I just heard from Dr. Hannigan that there was another study that did not, it was about equivalent, right? It was not superior. But there is an emerging evidence indicating that mycophenolate could be used as a first-line agent in inducing a remission. But we do have to be in mind that it is teratogenic, and that patients that are of childbearing age, they have to use double contraceptive, and most probably better to avoid that unless they are having intolerance to azathioprine. In terms of budesonide, the previous data did indicate that parallel to prednisone, or as on alternate to prednisone, budesonide plus azathioprine could be used to induce remission. However, the newer EASL guideline, based on, again, emerging data, was able to conclude that the expert opinion was that budesonide was not superior to prednisone plus azathioprine in inducing a remission, and therefore it should not be used as a first-line agent to treat AIH unless we have a specific contraindication in the use of prednisone. For example, patients that have poorly controlled diabetes, severe osteoporosis, uncontrolled psychiatric conditions. We should also note that budesonide should not be used in patients with cirrhosis and portal hypertension, particularly because there is shunting leading to cases of portal vein thrombosis that have been reported. So it shouldn't be used in cirrhosis and portal hypertension. And now the new guideline indicates that it should not be used with azathioprine as a first-line agent to induce remission. We covered that already. In maintenance of remission, ideally, patients should be steroid-free. That's the goal. Azathioprine monotherapy as lowest dose as possible. If they are on prednisone, 5 milligram or less. If they tend to be on budesonide, the dose should be around 3 to 6 milligram per day. So the lowest dose possible, and also steroid-free regimen is what is preferred to maintain patients in remission. I know I'm running out of time. Monitoring, I think they do need close monitoring depending on how sick they are. For example, an acute liver failure, I mean, we're monitoring every day. Those with significant liver injury, maybe every week. It can be stretched out depending on their response and how they are doing. I personally have only few patients that I'm checking labs every 6 months. Often I tend to monitor them every 3, see them every 6 if they are maintained. Treatment withdrawal is only possible for limited number of patients with autoimmune hepatitis. It doesn't, it takes time to get there. Often they need to be in complete biochemical remission for 2 years. So we need to make sure that that is clear to patients. They need to know the treatment goals and how long they need to be here, mostly lifetime commitment. And so I think we need to be clear to our patients about how long and if and when they would be able to come off of immunosuppression. That's not possible for many. Prior to withdrawing or decreasing immunosuppression, a liver biopsy should be considered. It is invasive. Many patients are not excited about getting a liver biopsy. We can look at other surrogate markers such as levels of ALT, often less than 50% of the upper limit of normal, IgG less than 1200. So I guess the level of IgG has been debated in recent data. But if we're withdrawing or decreasing immunosuppression, it's important to monitor them closely as relapse is very common. Before initiating immunosuppression, it's also recommended that we should check thiopurine methyltransferase activity, TPMT activity, as 0.5% of the population could be missing the activity. I tend to screen for latent TB, though the timing of treatment for TB can be challenging, especially if they have significant hepatitis. The screening for chronic hepatitis, either carrier or active infection, is very important. And patients need to be on antiviral therapy if they have chronic Hep B with positive surface antigen. And those that have core antibody positivity, they need to be monitored with hepatitis B DNA closely for any relapse so that we can add antiviral therapy. So there is a risk of hepatitis B relapse and chronic immunosuppression. So this is the background of AIH. I'm gonna switch gears to Dr. Spearman to go over the case presentation.